Okay, so I'll begin again. So I'm Dr. Rob Slocum. I'm the narrative medicine provider at University of Kentucky HealthCare as part of our integrated medicine service. And today I'm talking about narrative medicine, a communication therapy for the communication disorder of psychogenic non-epileptic seizures, PNES, a functional disorder. So that includes my email. So if there's anyone interested in further correspondence after this presentation, please feel free to contact me at robert.slocum@uky.edu. So narrative medicine is a communication therapy. It draws out the patient's narrative of illness or injury in the context of the patient's entire life story, inviting the patient to put significant experiences into words, allows dialogue. It's unstructured. It enables the patient to discuss what's most on their mind, but with guidance in the context of what's known to be happening between patient and provider. Rita Charon uses the phrase dyadic, dyad, provider and patient. So again, to emphasize, this is not like CBT, cognitive behavioral therapy, where there's a set list of questions, but rather to listen for what is most on the mind, or what's most important for the patient to discuss at that particular time. So it's patient-centered, open-ended, and unscripted. It may introduce new perspectives into the dialogue between patient and provider. Typical questions that have served as a starting point for these sessions would include, for the patient, what brings you here? What helps you the most? Do you see anything differently after the clinical experiences typically that have been mentioned? And what comes next? And what comes next actually taps into the patient's future orientation, their hopes, goals, sense of identity. And of course, narrative medicine seeks to work with the patient's sense of identity that may need to be renegotiated as they go through the process of treatment and hopefully through the process of recovery or whatever comes next. So narrative medicine is holistic, locates the patient's illness in the context of their life story, encourages insight, self-awareness, and understanding. Can also help the provider and treatment team to understand and appreciate the patient's concerns, challenges, resources, priorities, and goals. A way of testing their clarity, future orientation, affect, and other things can come out of what may seem to be a fairly routine conversation. As a discipline, it by name appeared in the late 20th century, but I'd urge that the use of narrative for healing has ancient roots, for example, in Native American tribal culture. One psychiatrist, Dr. Mel Madrona, talks about how in his own traditions, a healer, like a shaman, would never dream of treating a problem before getting to know the person who's going to be treated. In that case, maybe spending a day or two in that person's home. I'm not recommending it, but it just points out the importance of understanding the patient's context relative to the treatment, as in, say, Dr. Peabody's statement that patient care begins with care for the patient, including understanding of the patient and what motivates them, what their thinking is, what their feeling is. So narrative medicine helps the patient to renegotiate a sense of self, identity, self-awareness in the context of changing circumstances due to illness, accident, or even treatment. The patient may come to new insights. Back in terms of the questions I mentioned, the question, do you see anything differently, would oftentimes be an occasion for a patient's pause and then saying, well, yeah, I see everything differently since I've been receiving this treatment. Maybe to the point of saying, well, I certainly wouldn't want to have to go through this again, but I'd also never want to surrender the changes, the new insights that have come to me along the way. This recalls the work of Arthur Frank, who talks about narratives or dialogues of chaos, restitution, and quest. Chaos could be the moment where a troubling diagnosis and prognosis is delivered. the restitution, the patient's desire to go back to where things were before, but quest to go to something that's weller than well, to help in a process of individuation, growth, insight that the patient may not have ever come to or not come to for some time, but for the healing process that includes perhaps new insights and new understandings. Lassignol talks about the biographical disruption of illness, and narrative can help with that renegotiation of identity that comes through that process. So we can understand that our lives may have a collection of events, feelings, thoughts, but yet they constellate as a story many times. If I was speaking about in my own experience, meeting my wife, first year in graduate school, moving to a new place, there'd be many complex facts, feelings, thoughts, circumstances, but yet it would constellate as a story. So the idea that by drawing out the story, it's possible to have a deeper understanding of the patient and what motivates them, what moves them, what may still trouble them. So for those painful events that have not been structured to narrative, that may contribute to negative thoughts that the patient may be helpless to engage or move past. So constructing stories in the context of a trusted dialogue can help the patient to gain a sense of resolution, to move away from ongoing rumination and conscious thought about troubling past experiences. So that's just a quick overview of what narrative medicine, narrative therapy can offer to all kinds of patients. But now to move to PNES, which has been described by other authorities in the field as a communication disorder. So the PNES spells resemble epileptic seizures in some ways and must be ruled out by VEEG, but may include involuntary paroxysmal activity by the patient, may be described in catastrophic terms by the patient. The patient may often report that they feel like they're dying. It may be very disruptive to the patient's quality of life, independence, may be unable to drive, may be unable to maintain a job or complete schooling, may not even be able to fulfill family obligations. The episodes may be more likely to occur in public contexts, including provider examining rooms and waiting rooms. And so providers who may have patients to be treated who have PNES, provider advanced planning for those contingencies would be advisable. And they may be misdiagnosed and mistreated as epileptic seizures, and that has happened in the past. And in many cases, the treatments not only don't help, but may cause harm. So, and the misdiagnosis of PNES can further delay appropriate treatment. It's been estimated that in some cases, 7 or more years may intervene between the first presentation of the symptoms of PNES and an accurate diagnosis. Many providers haven't heard of the condition, so it's not in their differential. It has been at times described as an orphan disorder with no one discipline taking full responsibility for treatment. It may seem to fall between stools, not purely psychiatric or neurological, but yet oftentimes referred to providers. PNES as a communication disorder is not a language disorder. It's not an aphasia. The patient is fully able to form the words or form the sentences, except in the time of the episode itself, but rather it doesn't work for them to touch what has happened, to discuss it. It may be suppressed. So what may occur is that the body in time takes on a communication of its own ineffective communication. And if one particular symptom stops, it may be like we refer to as whack-a-mole. You push it down here and it'll come up somewhere else. It'll pop up. And that can be obviously very troubling for the patient. Who I've had patients come in to say, am I crazy? I mean, no. This is not about a sanity issue at all. It's about coming to terms with something that needs to be addressed. Family and social expectations may likewise inhibit the patient's expression of telling the story, exploring their feelings, sharing it with others. The family itself may have its own code of silence. We don't talk about those things. Isolation and stigma, even the medical terms used. I continue to hear medical providers refer to PNES episodes as pseudo seizures or hysterical seizures. These terms are obviously pejorative and could be hurtful for those people who may feel they're being accused of faking, malingering, doing something inappropriate. Some have been stigmatized by healthcare providers, coworkers, and family members, and indeed there have been clinicians who've verbally disparaged or even abused their patients with PNES with efforts to prove the symptoms were fake. I've actually had one patient who told me that her primary care physician, when she had an episode, said, "You can't do that in my office." I mean, this was as if to say she was, controlling it herself, when she, of course, was not. So PNES can be seen as a threat avoidant behavior, avoiding family conflict, avoiding facing an unbearable fact or situation that may be overwhelming, that indeed anguish in certain cases may be more than the heart can bear, so that the brain steps in and provides a diversion, but at what proves to be a terrible cost for the patient. So that PNES indeed may serve useful protective function, allowing the patient to escape from overwhelming, unspeakable trauma or stress, but again, at enormous inappropriate cost. It may reflect the repression of unacceptable emotion or disassociation from a distressing experience. In many cases, the patients with PNES have a traumatic history. In my encounters, more frequently sexual trauma, but also I've seen with other kinds of trauma, workplace accidents, automobile accidents, other very traumatic experiences. And the symptoms, these patients may be somaticizers. Just the onset of symptoms may actually serve as a warning signal to the patient and provider that the patient's stress level, for some reason, has increased. The patient indeed may be unable to hold the pain inside. So PNES, as I say, may result from these traumatic experiences. There may even be what we've referred to as developmental PNES, difficulty with facing milestones, the prospect of whatever, moving away from home or starting a new job or giving up work or facing the loss of a loved one upcoming that can be seen and anticipated. These could also be causes of episodes for those people with a propensity for somatization for PNES. The case study that I offer is based on a patient that I saw over a period of time who had been sexually abused as a child by a much older relative. Indeed, her earliest memory was of being abused by this older relative, but had been warned to keep silent. The patient herself said that she had worked through all this, and at first that seemed credible, but her symptoms and occasions seemed to keep leading back to this. And finally, after a time when she did worse and actually had at least suicidal ideation after being given an anti-epilepsy drug, she did come back to say, I believe I haven't worked through all of this. And at that point, the treatment really began to move forward. Her reported first PNES episode was in a shower, and as the unfolding story of abuse emerged, it appeared that she was actually in a home bathroom when first approached. Likewise, she found unexplained anxiety triggered in a medical test in which she was on her back in the dark and heard the sound of a closing door. But all of these triggers, if you will, could be related to her abuse history and the circumstances of her early abuse. And as she was able to talk through these situations, her symptoms diminished, were less frequent, and when they did occur, she saw them in a different light, didn't imagine that she was dying, didn't have to go to the emergency department for treatment, and she became increasingly able to enjoy good quality of life and indeed have a strategy for dealing with somatic symptoms if they should emerge. So the idea of the patient constructing a written or oral story about personal trauma, overwhelming distress can lead to a discovery through the narrative antidote of narrative medicine for the communication disorder of PNES. Discover hope, putting the unspeakable into words. Just to say that sometimes the patient may offer clues or what seem like random statements that may point to the reality of a diagnosis of PNES. Sometimes nightmares may have recurring images that relate to the trauma that they have faced. When it is possible to point out the connection. I've seen patients who were greatly relieved to have an explanation for why these seemingly unexplained episodes would occur, patients who were amazed to discover apparent coincidences between times when the episodes began and times when traumatic events either began or there were anniversaries or reminders of those events. When in fact it was no coincidence at all, and it wasn't some kind of master detective work, but just asking the question that frequently fits the pattern for patients with this condition of PNES. And sometimes the defensive mechanisms, if you will, of PNES may become more intense as they come closer to what's really being avoided. I've seen that happen in patients who, in the middle of a conversation, as it would become increasingly close to their central issue, would begin to have symptoms, would ask, is it getting hotter in here? Or would begin to show other visible symptoms or even a full-blown episode. But also in working through these things, they may come to an improvement in these symptoms. They may face a difficult history and be able to move forward in healing. So patient awareness itself that their events are psychogenic may be therapeutic. One study reports a remission rate close to 40% at 6 to 12 months, just when they realize where this is coming from, and there can be a beginning of improvement at that point. We talked about coincidence before. Patients may notice less frequent spells or less intense spells after accepting a diagnosis of PNES. The therapeutic use of narrative encourages improved patient communication and self-understanding, the improvements in the patient's overall life situation and strategies for stress management can also relieve the patient's sense of being overwhelmed, and other treatments or approaches that may help to lower the patient's level of anxiety may likewise prove helpful. So opportunities to talk further with a narrative medicine provider, opportunities for group discussion with others who have faced this condition could also be helpful. Beginning a process of communication and self-reflection about the traumatic subjects that can continue beyond the narrative medicine sessions and indeed provide a template for facing other traumatic situations that may occur in the future, so that those won't be as overwhelming or lead to the same intense somatic symptoms. So patients can discover new perspectives and insights to reframe their understanding, renegotiate self-identity with new hope. Narrative sessions encourage patients to communicate more effectively about the unspeakable traumas to reclaim their lives from the communication disorder of PNES. So, and I've got references, and I've included at the end of this, and I believe this is available through the conference materials as well.